Right, so my talk is about health inequality and what the NHS can do about it. So, why does health inequality matter? Well, here's a wealthy couple, let's call them Alice and Bob. And here's a poor man, let's call him Zach. The keener-eyed among you will notice A to Z, right? Z. Now, what's wrong with this inequality? Is it that Zach can't afford to go skiing? Well, not really. I think the deeper problem here is that Zach is clearly ill, both physically and mentally. And that illness has got a lot to do with his poverty. There's a link, there's a two-way link between wealth and health in all societies. So if you're poor, you've got a higher risk of becoming ill. And if you're ill, you've got a higher risk of becoming poor. These are slow, gradual statistical links. It's not the case that all poor people die young, just in the same way that it's not the case that all smokers die of lung cancer. But it's a real link. To see how real, let's have a look at this graph. This shows us current health inequality in England and Wales in terms of healthy years of life. What this means, it's your expected length of life, but adjusted for how healthy that each year of life is expected to be. So at the bottom here, we've got the richest fifth of people in this country having 75 years of healthy life, whereas at the top here, the poorest fifth have only got 63. So that's a gap of 12 years of healthy life between the richest and poorest fifth. So my research is all about ways of looking at the distributions of health and trying to help decision makers, particularly in the NHS, but also in other public services, to tackle that gap. This graph here shows why health inequality matters to the NHS. What we've got here is the relationship between social deprivation and preventable hospital emergency admissions. Okay, so the poorer folk are towards the right-hand side here. Whoops, I've gone too far. The right-hand side here, and they've got a higher risk of having one of these emergency admissions. In fact, they're 2.5 times more likely to suffer a preventable emergency admission than people like us, most of us in this room, who are in this group here, the least deprived fifth of people in this country. Now, these preventable admissions are things that the NHS should be able to do something about. They're admissions for chronic long-term conditions like diabetes, heart disease, dementia, respiratory conditions, these sorts of things that should be able to be managed in primary and community care. You shouldn't have to come into hospital, or at least you should be able to avoid people coming into hospital. So this is a sign not only of unfairness in society, but it's a sign that the NHS maybe isn't doing quite as much as it could do to tackle this inequality. It's also expensive for the NHS. So social inequality, we reckon, costs the NHS about £20 billion a year, about a fifth of the budget. What that means is that if we could have everyone in the country as healthy as the people in the most affluent neighbourhoods in the country, we could save all of those admissions and save all of that money. We could also save about, 158,000 preventable emergency admissions and about 38,000 deaths from treatable conditions. So, social inequality is actually costing the public services a lot of money. It's putting a lot of strain on services, constant pressures on waiting, in the news you hear waiting time targets being bust and so on. So, social deprivation is part of that problem. As well as being an issue of social justice, it's an issue that should concern all of us as users and payers of the NHS. So what is the NHS doing wrong? Well, the NHS can't do much about the structural imbalances of power in our society, but it can do things about individual behaviour, right? So a lot of these unhealthy behaviours are associated with low socioeconomic status: smoking, poor diet, lack of exercise, drug abuse, these sorts of things. There's a strong social gradient in all of these things. And, obviously clinicians can advise, they can give medical advice, they can provide behaviour change services like smoking cessation clinics, drug rehab, that sort of thing. although there's a limit to how far you can change individual behaviour. So what's really important is the NHS and other public services is the organisation of those services and the delivery of those services. So the NHS is very good at providing equal access to GPs and hospitals. Once if you have an emergency, you're there, you've got the access. The problem is the NHS isn't so good at preventing those emergencies, and it's not so good at following people up and providing proactive, coordinated long-term care for people after they've had the emergency. And that's where there is a real gap between the rich and poor here, because wealthy people, I guess, as I say, like us, we've got nice family support networks, we've got better information, we've got deeper pockets to pay for domestic services when necessary, nicer homes in which to recover from illness, and of course sharper elbows to navigate complicated bureaucracies like the NHS. So that's where really NHS staff need to pay more attention to these deprivation, to make sure that more deprived folk who don't have access to these resources can actually get the coordinated care they need in proportion to that need. So what we've got here is a sort of image of the average patient, the average family. This is what the NHS focuses on now. All their data stream focuses on the average. So you've got all sorts of indicators being, NHS clinicians and managers are bombarded with indicators, waiting time targets, financial targets, quality incentive schemes, all sorts of things. It's all about the average patient, the average family. What we need to do is split out those averages, split out that data stream by social group so that we know who gains and who loses from decisions, and we know the differences in quality and outcomes for different social groups. And that's what my research is trying to do. My metaphor for that is a prism. Basically, a prism takes white light and it splits it into the rainbow, okay? White light is all mushed up at the moment. That's the average. That's what the NHS is looking at now. And so I've got a picture of a prism coming up with some suitable music for you. And I'm going to show you the monochrome NHS to start with, and then I'm going to flick to the great, beautiful equity rainbow that will come out. And you get extra points if you can tell not only the band, I've tested this out before on Joan, but also the track. Okay, I want the track as well. So you ready? Okay, let's go for it. That's the monochrome NHS. Not very nice. Look at that. Beautiful. Are you getting it? Ah, there you are. That's why he's Vice-Chancellor. he got the band, but he didn't get the track. Anyone get the track? Well done, well done. It's quite subtle, that, yes, part of, yeah, well done. Okay, so, and thanks to Andy, by the way, the designer. He's not here today, but he did a great job in assembling that music for us. So the serious point here is that the NHS really does just focus on these averages all the time here. We need to split it out by social groups so that we can see who's gaining and who's losing and make sure that some segments of society aren't falling behind. Okay, how do we do that? All very well, music and so on. How do we actually do it in practice? So I'm going to show you two of the tools that we're developing. Firstly, what I call equity informative economic evaluation. So here's the equity impact plane. So on the vertical axis here, we've got cost effectiveness. So when the NHS is making financial decisions, it always looks at cost effectiveness, but it doesn't do any analysis of the equity impact on the horizontal axis here. So we've developed ways of doing that to place new decisions, financial decisions, within that equity impact plane. So great if we can have things that are cost effective and improve equity. Not so great if things are cost effective but increase health inequality. A lot of things are like that in public health, where you're trying to change behaviour. Physical exercise programs, it's always going to be the educated and wealthy who take them up more, so they tend to increase inequalities. And then you can get things in the lose-win quadrant, where it's more expensive to reach people in more deprived areas. And I'll give you an example of that. So this is bowel cancer screening programs. There's two programs here, two ways of reminding elderly people to take their bowel cancer screening test. Okay, one is the standard approach. You just give everyone a standard reminder. And what happens there is the more affluent, educated people tend to take it up, so you get actual increases in inequality. Whereas if you target and focus more intensively the reminder on deprived groups, you do reduce inequalities, you benefit this lot more, but you're actually slightly harming the affluent groups. Why is that? It's because you're using money for this program, you're taking that money away from other NHS services. So that's why the affluent slightly lose here. So basically, we've got a trade-off here. The targeted approach, the focused approach, reduces health inequality, but it's not as cost-effective as the standard approach. So it's just important that decision makers have that information. I'm not saying which decision they should make. I'm just saying they need that information to think about these things and maybe redesign programs so that they're inequality reducing. Okay, second tool, equity informative quality indicators. So this is back to our preventable emergency admissions. This time it's within a local area, Brent. So the dots here are neighbourhoods within Brent, and bigger dots are slightly bigger neighbourhoods. What we do here is we show the relationship between deprivation on this axis and emergency admissions on this axis, and the green line is the one to watch. That's the regression line that joins the dots. It summarises information in the dots, and it shows there is a relationship between being deprived and having a greater risk of emergency admission. But what we notice in Brent is that line is below the purple benchmark line of similar areas. So Brent is doing better both on average and better in terms of inequality. So well done, Brent. Now we're going to look at Liverpool. Not so good. A lot steeper, the line, and higher up. So they're worse on average and worse for inequality. Crucially, when we compare that purple line again, these are similar areas to Liverpool, places like Newcastle, Sheffield, large metropolitan areas similar to Liverpool. They're doing better. So Liverpool maybe can learn some lessons here and think, well, what are we doing wrong here? And in fact, what we can do is we can track how Liverpool is doing over time. And these indicators that the NHS has now published will be updated quarterly. So we'll see, NHS have got all these fantastic, Liverpool have got all these fantastic plans for coordinated care in their area and improving services. So we'll see if that actually reduces inequalities and learn some lessons over time from that. So those are our two sets of tools. Some of them are starting to be used by the NHS, some are in process. We're in conversations with NHS people about our equity informative economic evaluation. We're in conversations actually with people in other countries about this. We're hoping that they're going to be used regularly to inform decisions in the future. And the idea is to use these tools to help break that wealth-health link and start clamping down on this 12-year gap in healthy years of life between rich and poor. Now, of course, it would be great if we could reduce the bigger wealth inequalities in society, some of the things we've heard about earlier. But my focus here is specifically on that link between wealth and health. So, you can disagree about, you have different views on how much inequality in wealth there should be in society, but I hope you'll all agree with me that whatever the distribution of wealth is, it's not fair that poorer people should have shorter lives than richer people and have more illness. That doesn't seem to be fair, and so we need to redesign our public services to clamp down on that, to focus on the equity prism and start reducing that 12-year gap. Finally, before I sign off, I just want to say real special thanks to Mikdad and Shazad for all their help with this research. Fantastic colleagues. And also I want to thank my funding bodies, particularly the NIHR, and there's a sort of cast of thousands there of other people who've helped with me. So I want to thank them very much for helping and continuing to help with this work. And I want to thank you for listening. Thank you.